Welcome to our video discussing the cardiovascular manifestations of long COVID, a condition caused by COVID-19 that is gaining traction and starting to be understood by the medical research community. The acute form of severe COVID-19 is still a present danger. However, a unique and fascinating component to the pandemic is the appearance of long-term complications. In this video, we will explore the challenges in defining long COVID, the most commonly reported symptoms, and the debate surrounding the prevalence of these symptoms. We will also discuss the major risk factors associated with long COVID, as well as the protective role of COVID-19 vaccination. Furthermore, we will delve into recent studies that have discovered an increase in cardiovascular complications in the year following acute COVID infections, ranging from dysrhythmias to thrombotic disease. Join us as we present the current understanding regarding the cardiovascular manifestations of long COVID, the established natural history of these complications, and identify data gaps in the published research. To give you an idea, a study conducted in the United States looked at patient data 30 days or more after being infected with COVID-19, focusing on the side effects and complications they experienced during this period. The research focused on post-acute COVID-19 infection, excluding acute cases. The study's findings showed a significant increase in various complications, highlighting that the more severe the COVID-19 infection, the higher the risk of developing such complications. The results were categorized as follows. In green, patients who were not hospitalized. In red, patients who were hospitalized. In purple, patients who were hospitalized and required ICU. Even after 30 days of the initial episode, patients continued to face complications, including cardiac arrhythmias, inflammatory heart disease, cardiac ischemia, cerebrovascular diseases, other heart diseases, and thromboembolic events. The study emphasized that the more severe the infection, the higher the risk for patients to experience these health issues. One of the cardiovascular manifestations of long COVID that has emerged in recent studies is an increased risk of cerebrovascular disease, such as stroke and transient ischemic attack. Patients commonly present with acute focal neurologic dysfunction, including difficulty with speech or localized muscle weakness. The link between acute COVID and cerebrovascular events is well documented, with studies reporting a prevalence of stroke in acute COVID patients ranging from 0.5% to 1.5%. However, the risk of such events during the long COVID timeframe is less clear. Recent studies have found that within a year following a COVID diagnosis, patients had a 52% increased risk for stroke and a 49% increased risk for TIA compared to COVID-negative patients. While there is not conclusive data regarding the mortality and functionality outcomes of these events in the setting of long COVID, multiple studies have shown that the mortality of patients with cerebrovascular disease in the setting of acute COVID-19 is greater than in patients who were COVID negative. The proposed mechanisms for the observed increased risk of cerebrovascular events in the acute setting include angiotensin-converting enzyme inactivation, increased coagulopathy, and central nervous system vasculitis. However, it has yet to be elucidated whether these mechanisms persist for the duration of long COVID. Long COVID has been associated with a wide range of dysrhythmias, including postural orthostatic tachycardia syndrome, inappropriate sinus tachycardia, atrial fibrillation, and atrial flutter. While estimates of the frequency of these dysrhythmias in long COVID patients vary, it is clear that postural orthostatic tachycardia and inappropriate sinus tachycardia are more prevalent, while AFib and atrial flutter are more clinically concerning. Postural orthostatic tachycardia is defined as a dysfunction of the autonomic nervous system characterized by tachycardia, palpitations, lightheadedness, and syncope commonly experienced when patients stand up or are showering. While there are no conclusive data on the frequency of postural orthostatic tachycardia associated with long COVID, it has been described in the literature. Proposed mechanisms by which postural orthostatic tachycardia may develop in COVID-positive patients include hypovolemia or deconditioning to destruction of cardiac stimulating sympathetic nerves, changes in brainstem functioning, or autoimmunity. Inappropriate sinus tachycardia is a frequent and well-documented sequela of long COVID. Patients often present with a variety of symptoms including palpitations, shortness of breath, and dizziness. One study performed electrocardiograms on 200 long COVID patients and found an inappropriate sinus tachycardia prevalence of 20%. Long COVID patients showed a significant increase in rates of palpitations, dyspnea, chest pain, headache, dizziness, diarrhea, and dermatologic alterations compared with patients who fully recovered from acute COVID-19. The disease burden of inappropriate sinus tachycardia was established at 5.78 years. Long COVID is associated with an increased risk for IST, though the mechanism by which this relationship develops is still unclear and requires further investigation. AFib and atrial flutter have also been linked to long COVID. Studies have found COVID-positive patients to be 1.71 to 2.41 times more likely to develop AFib or atrial flutter compared with COVID-negative patients at 12-month follow-up. The disease burden of AFib for long COVID patients was 10.74 years, and that of atrial flutter was 3.10 years. The increased risk for AFib development can have a particularly large disease burden on patients. One proposed mechanism between COVID infection and AFib focuses on the effects viral-induced cardiac fibrosis and altered intercellular coupling leading to abnormalities in conduction and repolarization. As the pandemic continued to rage on, cases of inflammatory heart disease continued to be reported. Among the most concerning conditions were myocarditis and pericarditis, both of which were linked to acute COVID-19 infection. Despite inconsistent results in research studies, the prevalence of these conditions remained high in COVID-positive patients, and even those who were vaccinated were not immune to their risks. As the clinical picture of COVID-induced inflammatory heart disease became clearer, it was evident that these conditions were both prevalent and debilitating. The mechanism of myocardial damage was less likely direct infection of the myocardium by the virus but rather due to systemic inflammation, while pericardial damage was most likely due to cytokine and T-cell-induced injury. However, the differing time course of presentation in pericarditis suggested a complex and dangerous clinical picture of COVID-induced pericarditis, in which there was a delayed onset. Despite these challenges, doctors continued to work tirelessly to diagnose and treat these conditions in their patients, relying on the latest research to inform their decisions. With so much still unknown about the long-term effects of COVID-19 on the heart, it was clear that there was much work yet to be done to fully understand and combat this deadly virus. Studies have found that COVID-positive patients have an increased risk of angina compared to COVID-negative patients, which is concerning given that angina is also associated with an increased disease burden for long COVID patients. Moreover, there have been reports of myocardial infarction in patients with acute COVID infection. Symptoms of myocardial infarction can include dyspnea, nausea, fatigue, and weakness, with chest pain being less frequently seen in women. This is a serious complication that can arise from coronary artery disease, and it's important to note that COVID-19 may increase the prevalence of coronary artery disease and therefore raise concern for more serious complications such as myocardial infarction. There's still a lot that we need to learn about the exact mechanisms behind this association, especially for patients suffering from long COVID. Studies have proposed that direct myocardial injury, increased cardiac demand during infection, and immune dysregulation may be contributing factors. But as with many of the other cardiovascular implications discussed in this article, more research needs to be done to fully understand the relationship between COVID-19 and cardiovascular disease. Cardiopulmonary symptoms are common in long COVID patients and can be linked to the cardiovascular system. Patients may experience fatigue, dyspnea, and chest pain weeks after being discharged from the hospital for COVID-19 infection. These symptoms raise concern for underlying cardiovascular pathology and indicate the need for a more extensive cardiopulmonary workup. Reports of venous thromboembolism during acute COVID were frequent and concerning. However, it is debated whether patients suffering from long COVID continue to be hypercoagulable. DVT is usually found in the leg in patients typically present with unilateral leg pain, swelling, and redness. Depending on their size and what arteries are occluded, Pulmonary embolism can be asymptomatic or cause acute onset dyspnea and chest pain. Large-scale analyses found an increased risk of thrombotic events in long COVID patients, with some studies reporting a 2.648 times increased risk for pulmonary embolism and an 87.9% increased risk for DVT. It is unclear if the risk of thrombotic events is elevated due to COVID or if it is due to other factors such as hospitalization. Ultimately, VTE in long COVID necessitates an important clinical balance when weighing the normalized risk of VTE after a few weeks with the severe consequences of a DVT or pulmonary embolism. While there is still conflicting information regarding the prevalence and sequelae of long COVID, there are clear increases in cardiovascular events in patients. Many complications appear to be due to increased inflammation throughout the body, but more details are required to elucidate the true causes of these symptoms. When focusing on cardiovascular specific symptoms, general cardiopulmonary symptoms are most common, but there is a significant increase in risk of ischemic and inflammatory disease. Cerebrovascular, ischemic, and thrombotic events have the largest burdens due to their likelihood for morbidity and mortality. Thank you for taking the time to learn with us today. Please share this video with your colleagues, subscribe to our channel, and give us a positive evaluation. We hope to see you soon in our next video.